Well, I trust everyone rested well. Very good, very good. Well, we're going to get into some greater detail today, and specifically starting out regarding diagnosing an MPN. We'll see about the clicker here. Better world here. Voila, alrighty. So the diagnosis of an MPN. So the MPNs clearly can have various different groups as well as issues of progression. Early on, we have patients with Polycythemia Vera and ET, and perhaps those with early myelofibrosis, and we'll get around to that in a moment, that clearly can have a set of challenges as we discussed yesterday. Now, over time, we can have myelofibrosis. Now, the confusing terminology is that we have both patients who are initially diagnosed with myelofibrosis, that's the first disease that we encounter, or they have progressed from Vera or ET previously. From here, the difficulties with the diseases we discussed yesterday, difficulty with symptoms, enlargement of the spleen, potentially drops in the blood counts. Myelofibrosis can progress to acute leukemia, and patients, unfortunately, clearly can pass away from the illness. So how do we diagnose these diseases? Well, Carlos yesterday mentioned the WHO criteria. The World Health Organization is a large organization and involved with a whole variety of different collaborative efforts on health, and with that includes a variety of diagnostic standards for many diseases, including the different blood diseases. So whether it's CLL next door, whether it's MPNs, CML, acute leukemia. Now in all the MPNs as a theme, the diagnostic criteria involve a variety of steps. As we think about diseases as physicians, there are some diseases that the presence of a single test will tell you have a disease and what that disease is. And CML perhaps is one of the most classic, where that can be a defining diagnostic criteria, having the BCR-ABL specifically for CML, although it can be present in ALL. But in the MPNs, it's a little bit more convoluted. So first, let's start with a criteria for myelofibrosis or primary myelofibrosis. It requires meeting three major criteria, and I'm not going to read them, but I'm going to tell you what they are really saying. One is that the bone marrow looks consistent with myelofibrosis. This is the most complicated part, and that's why having someone look at the bone marrow that really knows something about bone marrow diseases is important. Second, not having a different MPN. Sometimes that's easier said than done. So it's easy to list this criteria, but it means that you have to go through these other criteria and make sure it's not something else. Three, and this is what's very key, the presence of one of those markers of which we discussed several times yesterday, JAK2, CALR, or MPL. The majority of patients with MF will have one of these. Not every patient, but the majority. The minor criteria are also important, typically having one or more of these features: anemia, an increase in the white count, an enlarged spleen, or an increase in the blood test known as the LDH. So as you can see, this is almost like its own puzzle piece, as your physicians sit with all of these different pieces to try to come up with a diagnosis. Now, amongst myelofibrosis itself, it's a bit confusing that the term myelofibrosis means scarring in the marrow, but it also refers to the disease. And the fact that it refers to both does create confusion. The actual scarring in the bone marrow, there is a set of criteria to discuss how much scarring is present. There are criteria for Polycythemia Vera and essential thrombocythemia. Again, similar idea, clinical features and bone marrow features. For Vera, it's an increase in the red blood cells, and the numbers as to how many red blood cells or how high the hemoglobin has changed over time. The most recent version decreasing that somewhat to be sure we don't miss anyone with Polycythemia Vera. Second, again, bone marrow changes. And this could be paragraphs of description. What does a bone marrow like Vera look like compared to someone who does not have it? And then finally, and particularly in Vera, where this is highly relevant, the presence of one of these mutations. In Vera, where about 95% of patients will have one of these mutations, the absence of one of these makes us very suspicious that someone does not have polycythemia vera. It's still possible, but it's highly unlikely. Other criteria are in the blood, a decreased erythropoietin level, a measurement of a hormone in the blood. With the ET, we have its own set of criteria, too many platelets. Again, a very long description for the pathologist trying to distinguish ET from early myelofibrosis, an area of which there is controversy, largely because it is subjective. It's not an absolute test like a pregnancy test that's yes or no. It's a test that says, I look at this bone marrow and I think it's ET. Third, again, not having another MPN and then having one of these mutations. Now, so those are the criteria for each of the diseases. We also have criteria for what is progression. Now, this is important. If someone's had Vera or ET for years, and for many of them, typically 10 years or more, and they come to see Claire or Carlos, say, over the last 12 years, I'd been doing fine. I had my Vera, but something changed about 6 months ago. And it's those changes that can be a sign of progression. In the bone marrow, there can be an increase in scarring, and we have to be pretty sure that they actually had Vera or ET to begin with. So sometimes if the very first bone marrow they've had is at the time of progression, it's more difficult for us to know for certain that there has been progression. Now, patients will clearly come to me sometimes and say, boy, nothing is different, but my doctor repeated a bone marrow, and now they see 2+ scarring. Do I now have myelofibrosis? And the answer is both yes and no. You do have some scarring in the bone marrow, but you don't have the disease yet that we call myelofibrosis, because that disease has two parts, a change in the bone marrow, but a change in the clinical features. The disease changes. So what are those clinical features? One, typically a change in the blood counts. I used to need a lot of phlebotomies, now I don't need any, or I'm even anemic. Two, there are cells in the peripheral blood that aren't there that are now there, such as blasts that were not there before. Three, a clear increase in the size of the spleen. And four, a change in the symptoms. For me in particular, if patients have unexpected weight loss, if they have very severe bone pain, fever, there are some symptoms that we see much more in myelofibrosis than we see in patients that have earlier disease. So typically the patient who comes to see me and says, boy, nothing is different, and I've been told I've changed to myelofibrosis, they probably are not there yet. Now, if we see scarring in the bone marrow, we are concerned, are they moving towards this? Is this something coming in the future? But it's a clinical change as well as a bone marrow change. Now, the spleen is part of this. As we mentioned yesterday, the spleen is enlarged in most people that have evolved to myelofibrosis, although perhaps not 100%. Now, why do we care about the spleen in these diseases? Well, yesterday I talked to you a little bit about the biology of the spleen, but why the spleen is a factor in these diseases and is different than the discussion of the spleen in CLL. In CLL, the main issue with the spleen is that the spleen is filled with lymphocytes from the chronic leukemia. It's basically just too many of those cells. In MPNs, it's a bit more complicated. There's both mechanical side effects of the spleen being enlarged. It creates fullness. It interferes with my ability to eat. It might interfere with my bowel habits because it's sitting on my organs. It can act as a filter for the blood and a little bit like the tax man for the blood. What I mean by that is if a patient with myelofibrosis has a big spleen and we give them 2 units of blood, there are times that the spleen might destroy even up to a full unit of the 2 units of blood. So people don't have the full benefit of that transfusion. Now, what about the progression that most of us really want to avoid, the most concerning, which is a change to acute leukemia. So acute leukemia has several different synonyms in the context of MPNs. Some of us will refer to it as MPN blast phase. Some of us will refer to it as acute leukemia. What we're implying is actually specifically acute myeloid leukemia, although there are very, very rare circumstances that MPNs have changed to acute lymphocytic leukemia. That really is exceedingly uncommon. It is different if we were having a discussion with chronic myeloid leukemia that sometimes can change into acute lymphocytic leukemia. Now, how we define acute myeloid leukemia in someone that had an MPN first are either blasts in the blood over 20% or in the bone marrow greater than 20%. Blasts are the earliest cells in the bone marrow. Normally they stay put in the bone marrow. Normally they're less than 5% in the bone marrow. So this is a clear increase. Now, why that matters is that when that change occurs, there is a sharp drop in the ability of the bone marrow to make the other cells that we need. So it's less about the blasts and more about the impaired function of the bone marrow, where people have drops in the useful white blood cells known as neutrophils, excuse me, platelets, or hemoglobin. So for me, acute leukemia is risk. It's risk of infection, it's risk of bleeding, and it's something as physicians we clearly wish to try to avoid. Now, we discussed a little bit yesterday around trying to assess risk with these diseases. Now, risk is helpful in terms of guiding us in terms of treatment, but it is incomplete. It doesn't tell us how much an individual is suffering with a disease, but it does give us a little bit of a sense of what are some factors that tell us the disease is a bigger problem, more likely to be life-threatening, more likely to progress. One is clearly the issue of age. As we get older, we have greater risk with an MPN. Not a big surprise. In part, it might be due to the presence of other diseases. We're more likely to have heart disease. We're at higher risk of having a heart attack or stroke anyway. So it probably feeds off of other risks. Two, increase in the white blood cells. Whether we're talking ET, Vera, or myelofibrosis, increases in white blood cells are a sign of the disease perhaps being a greater challenge. Next, these factors which we consider for myelofibrosis: anemia, symptoms, and increasing blasts. They can be signs of progression, signs of greater risk. Now, in myelofibrosis, Carlos mentioned this yesterday, but I'll re-emphasize it just to show you as we think about risk in these diseases, we think about clinical features, blood counts, symptoms, and movement towards acute leukemia, and increasingly we're thinking about those molecular changes. Now, what about symptoms in this mix? Well, symptoms are an important part because, as I mentioned yesterday, they tell us a lot about the disease, but they also tell us a lot about you as individuals. The symptoms can be present across the spectrum of these diseases, but there are certain symptoms that tell us different aspects about the disease. Mentioned earlier, issues of vascular events. One thing we've learned regarding symptoms is that vascular events, we used to think in the past, was only a blood clot or bleeding. We recognize now that there can be symptoms related to issues with vascular flow short of a blood clot. We know that migraines that affect your vision, difficulties with concentration, are all part of that spectrum of difficulties with blood flow. We know that drops in the blood counts are important, both because of the impact they have on the body. If you're more anemic, you're more fatigued, but as well you might have greater difficulties with breathing, concentration, and other difficulties. Risk of progression is a concern. The spleen can affect us, obviously, in a variety of ways, as can our symptoms and baseline health. Now, as we look at low blood counts in this mix as to how they contribute how we feel, it's important to recognize that the majority of drop in the counts that we deal with are around anemia. Only about a quarter of patients with myelofibrosis may have a normal hemoglobin. A drop in the platelets is present in about a third of patients, and drops in the white blood cell counts are very uncommon. Now, as I try to think about symptoms in the disease and what they tell us, we try to put them into different buckets. There can be different symptoms that are related with the enlarged spleen, just due to its sheer size. There can be sharp pain in the spleen, sometimes from lack of sufficient blood flow. There can be symptoms that are associated with inflammation, including itching, bone pain, fevers. There are some symptoms really related with the body's metabolic system being overly active. That is part of that fatigue, night sweats, and inadvertent weight loss. In some individuals, there can be a burning of calories that really is higher than the normal rate. And then finally, there are the symptoms really related to the issues of blood flow. To try to quantify these, our group had been really working with many of our colleagues to try to quantify these difficulties. We developed the Myelofibrosis Symptom Assessment Form to look at issues of constitutional symptoms, spleen, fatigue, and quality of life. We then added symptoms originating from a vascular risk and mood-related symptoms and created the MPN Symptom Assessment Form as well as the 10-item form. With this now we have data in all of these different languages as well as information from around the world. Using the 10-item form, we've used this in a variety of settings, including in ongoing clinical trials, and one can really try to track a change in individual symptoms over time. We're working on trying to move this from being just in clinical trials to being in practice, where individuals either through an app on their phone, on a website, through perhaps their electronic medical record, we can track these things. So in my ideal world, in the future state, if a physician visits with you, they have your blood counts on one sheet, but they have a change in your symptoms on the next sheet that they look at. Both are relevant. With these 10-item forms, we could see that the majority of MPN patients have at least one of these symptoms typically. In green, you see that they're most common in myelofibrosis, with perhaps itching being the sole outlier, being in particularly common in patients with polycythemia vera. With these, we've seen that these symptoms can overlap. Increasing red shows us increasingly problematic symptom groups. And with this approach, we could see that this group that is most symptomatic is most common in myelofibrosis, but a surprise to many physicians is also common in ET and P. vera. We can see that there are certain symptoms that cluster. Certain symptoms go with other symptoms in groups. We could see that the duration of having an MPN has an impact on our symptom burden as well. The longer you have an MPN, it's an evolving chronic disease, and the symptoms can evolve along with it. In terms of individual symptoms, we've learned that, again, there are many aspects we need to consider. Claire mentioned yesterday a little bit about the impact of gender, and we had found and published earlier this year that in general, female patients with MPNs have higher levels of fatigue, more abdominal symptoms, more microvascular symptoms, and a higher total symptom score. And this may have a variety of different important contributors. We've also studied many different aspects that really have not been studied before. We've looked deeply into insomnia. Insomnia is incredibly common amongst patients with MPNs. It is common amongst the general public. But in MPNs, we particularly can associate insomnia with difficulties from specific symptoms. Headaches, depression, numbness or tingling, night sweats, itching, fevers. So again, if you are laying your head down on the pillow, perhaps you use that wonderful lavender spray that we got in our rooms last night, maybe that helped. But if you start having night sweats and are itchy, you're certainly not going to be sleeping well. So all of these things are tied together. We've also found a big impact with intimacy. The issues of sexuality that you never hear about in an MPN conference, but it is a very important and difficult problem. It was the second most common symptom around the world in all of those different countries. And why? Again, if you're itchy, you're having night sweats, the last thing you really are interested in is this issue of intimacy. So in a lot of ways, it's a very good litmus test for me for how well people feel. So that if you don't feel well, this is something that goes out the window and is a very good metric in terms of how imbalanced someone feels in terms of their health. So I'd conclude by saying the diagnosis of MPNs are complex, and although clear for some patients, it's sometimes more difficult to make an accurate diagnosis. Progression exists on a spectrum. Individual patient symptoms are linked to other symptoms and different domains. And again, low risk does not necessarily equate to low symptom burden. So I'm frustrated where I hear the patients with ET or Vera that have been told or feel like their symptoms or difficulties have been dismissed because they don't have myelofibrosis. Indeed, these are difficulties that can exist on a spectrum. And with that, I see it's time for the next topic. Thank you.